Hello and welcome back to our Arthritis Ireland conversation series, Surgery and Arthritis. I'm Gráinne O'Leary, Chief Executive of Arthritis Ireland. Our mission in this series is to bring you up-to-date information on a range of treatment and management options for arthritis. During these episodes, you will hear from expert voices from across the medical spectrum as we strive to answer some of the more common questions you may have and to gain some insight into the latest medical research relating to these conditions and treatments. Today, I am joined by Gavin McHugh, Consultant Orthopaedic Surgeon at the UPMC Sports Surgery Clinic in Santry, where he specialises in hip and knee surgery. Taking the decision to have any kind of surgery is no small matter. This video will offer insight into what is involved so that an informed decision can be made if you are considering surgery. It will also provide information on preparing for surgery, the different types of procedures, as well as what to expect during recovery and from life after surgery. Gavin, thank you so much for joining us today.
And thanks for having me, Gráinne. Great to meet you and the team, and indeed thanks to Arthritis Ireland for having me along as well. So yeah, I'm looking forward to it.
Okay. So, my first question for you today is, when it comes to surgery and arthritis, what are the factors that inform whether it's necessary to have this sort of intervention in the first place?
So I suppose I'd nearly stop you there in using the word necessary. Right? Quite often when it comes to a joint replacement, strictly speaking, it's not really necessary. It's whether somebody would benefit from it, all right? And I think it is important to sort of like make that little bit of distinction in that ultimately it is up to the person whether or not they decide to go ahead. It's not like, it's not like a broken leg that absolutely needs fixed, all right? But in general, you could look at these things in terms of pain and disability, all right? The overriding factor that drives someone to have, and again, I'll talk mainly about hip and knee replacements, as that's my area, but that what drives people to have towards surgery is pain. That's the overriding factor. The vast majority of people have pain, all right? Disability can come into it, but it's generally a secondary thing, but I'll talk about that again. And in terms of the pain, again, we can go into it as much detail as you want. For me, one of the sort of deal breakers is night pain, all right? So especially with the hip, you'll find that people get to the point where they're wakening from sleep, 1, 2, 3, 4, 5, 6 times every single night or most nights, all right? And ultimately, that's when you often would benefit from having something done, all right? Again, then, in terms of pain throughout the day or with activities, if things are holding someone back from doing their activities that they want to do, all right? Or indeed just really, affecting their quality of life as they're doing them, then if this isn't controlled with simple analgesia, then again, it's often a time to start thinking about having something done, assuming, it fits the bill in terms of the diagnosis.
Okay. And I suppose when we talk about maybe some of the alternatives to surgery that people living with arthritis might explore, before considering that option of surgery, what might they be? What might they be?
Well, we have a sort of saying for it is, as we're sort of we're often taught to sort of say, assuming that conservative measures have been exhausted, all right? And that's just a way of saying, yeah, we've dealt with all that there stuff. It's now time to talk surgery. So that is something that's really important to all of us as well. And ultimately, not only in that can you sort of, potentially gain months, even years without having to have surgery, all right? You can potentially set yourself up a lot better off if in the event you do require surgery, all right? So, yeah, things like weight loss, we'll probably speak about again, can be very important. Just pure strengthening activities, so anything that works, particularly again from the hip knee point of view, your quads and your glutes in particular can benefit. Strictly around the hip, I find a lot of stretching activities can actually potentially precipitate even more symptoms rather than improve things. But within reason, just keeping more active actually tends to do good, not bad, all right? From the analgesia point of view, simple analgesias such as paracetamol, which everyone sort of turns their noses up at initially, but it comes with a very sort of low side effect profile, all right? And it's often worth worthwhile trying to just take the age off things, and that then, as you move up, assuming that you combine that with potentially with anti-inflammatories. Opiate type of medications for us are, for the vast majority of people, avoided. They tend to come with too many side effects, and they don't particularly work really well for musculoskeletal type pain. They work better for other types of pains, cancer type of pains, all these things. They have a hugely important role. But for us, for joint pain, they're not great at relieving it. And even if they do, with time, you tend to become tolerant to it. So you don't get the effects with time. So for me, just paracetamol and anti-inflammatories.
Okay. And this is probably linked to the first question I asked you, but, at what point would surgery, be considered the best option for people?
So again, that's where you have to sort of like weigh up how it's affecting you day to day, and have you more to gain than you have to lose in many ways. And when someone's quality of life is disrupted to such an extent that they have more to gain than they have to, then that's when it's worthwhile considering. And I often say to people, like, not to sort of knock golf, but we, I see people who get a little bit of groin pain, for example, in their hip on the 16th or 17th hole of a golf course, right? And that's it. And they play once a month and that's it, all right? I also see people who would wake 6 or 7 times every night. I see people who have slept in an armchair for 2 years because they haven't been able to lie down flat in bed, and who could take 20 minutes to get to the bathroom. So those two ends of the spectrum, all right? The vast majority of people are somewhere in between, all right? And again, it's, are you erring towards the more severe spectrum, or are you erring towards the sort of the conservative, where literally your paracetamol or whatever helps, all right? And this is something that I knock home to people. You often don't have to be as bad as people think they have to be to benefit from a joint replacement. And we know from loads of scoring systems that we use in patients and outcome measures that if you sort of divide them up in terms of severity, the group who benefit most from a hip or a knee replacement are those with moderate symptoms, all right? Now, it's very obviously subjective in terms of what's mild, moderate, severe, but the moderate group are the people who are just about able to still do their normal day-to-day activities. So in many ways, they're ready to hit the ground running again after they get the joint done, and they'll rehab quite quickly. Whereas the really severe group, the person I spoke about who has slept on an armchair for they have a huge amount of work to do following the surgery in terms of getting back to their pre-sort of morbid level as such. So there is a happy medium. It's often not as bad as you think, and all too often, with hips especially, I find that people come in and they almost feel like a fraud. All right, they think they're not bad enough, and
they feel they haven't reached that point where they.
And this is what a hip does to people. A hip slowly drags someone down, with sort of everyone around them being aware. So their husbands, wives, their children, everyone around them will be like, "Oh, would you forever go and get that thing? You're always limping around." And the response, I'm not too bad. And I always just put it down to the human condition, that our nature is to sort of like adapt and cope with things, and we just manage to get on with it. And genuinely, it's not that they're in denial. They don't actually realize they're as bad. And I often sort of describe it as a little bit like a background noise or something, that until you turn off that noise, people don't realize that it was as bad as it was.
Does their pain become normalised really in their daily activities?
Yes, I don't know, but they're just so used to it that it's only afterwards that they're like, oh my God, I was way worse than I actually had given credit for it, So so lots of times it is a case, and it's not to try and build up everyone's symptoms, not at all. But I would spend sort of half the time reassuring people they're not as bad as they think, and the other half of the time, actually going, I think you're a lot worse than you're letting on to yourself as well. So it's a strange one.
Right. And in terms of, obviously, surgery has all sorts of connotations. They are big procedures. But what types of risks should people be aware of, before surgery takes place? And, what questions do you recommend that a person asks their doctor or surgeon before undergoing the procedure, so that they gain as much information as they can?
Yeah, so, it is important to consider that a joint replacement ultimately is still a joint replacement. It has moved on, I think, an awful lot in terms of how we go about it and the safety profile of it compared to, say, 40 or 50 years ago, all right? But it is still, as you say, it comes with significant risks, although rare, thankfully, all right? And overall, the odds are very much in your favor, right? So if you look at sort of satisfaction rates or after, say, a hip replacement, you're talking 96, 97%, that sort of rate, which is pretty hard to replicate in lots of other surgeries that are performed. Everything comes with a sort of the standard risk profile. Infection is always our nemesis, right? And again, if someone, as a surgeon says, they've never had an infection in their practice, it's absolute nonsense. Everyone gets them. It is just a fact of life. And trust me, we take the utmost precautions in terms of avoiding that. But again, anywhere for a deep joint infection, you're talking about 1 in 300, all right? Which it's not that common, but it's still a significant risk when in terms of you're going and you're thinking of rolling that dice, all right? Things like clots in terms of like either deep venous thrombosis or pulmonary embolism, again, that's a risk factor. You're probably talking about 1 in 500 to 1 in 1,000, that sort of rate nowadays. How do we get around that? We give you sort of foot pumps, we give you stockings to help encourage the circulation. Most importantly, we get people up quickly, and lots of our joints are mobilized the same day. The quicker we get people up, the lower that risk becomes in terms of clots. And you're usually then also given some form of blood thinner then thereafter as well to help prevent it. Nothing absolutely reduces the risk. Some people are definitely more prone than others to these type of events. But thankfully nowadays it is uncommon, all right? Then more specific things with regards to the joints. With a knee, stiffness would be one of our main issues, in that a knee replacement can end up stiffer than the native knee that was in, and just purely pain. A knee is hard work afterwards, and I always describe it's not that you get a hip for free as such, but a knee most certainly makes people earn it, right? In terms of the recovery, and it's it's not a 6-week job, it's a sort of 6-month job in terms of that recovery. And I think it's important to people, that whilst we support people, whilst we give them analgesia, it is going to be sore, and that's important to know. Then with regards to the hips, hip popping out of the socket or dislocating, all right, is still, again, in comparison to, say, 20, 30 years ago, when dislocation rates were potentially 5%, it's much less common now. It's 1 in 2, 1 in 300 type of rate. We use a bigger head in terms of the prosthesis, so essentially it has to jump the radius in order to get out. Right? Okay. So years ago there was a 22 millimeter head that was used. Now it's usually, most surgeons will use a 32, if not a 36 mil head. So that comes with a lot more stability as such. All right. In terms of, we always sort of quote things like damage to sort of the bone in terms of a fracture, damage to the nerves around there. Again, it tends to be very, very rare nowadays. I mean, that would be unlikely that anything untoward like that happens during surgery.
Okay, I'm going to take you back to something you talked about earlier. Was around what people can do themselves to in terms of, it partly feeds into the conservative techniques, but also post-op as well, and that's about maintaining a healthy weight and building up muscle around the joints in advance of surgery. Does that help to improve outcomes?
Absolutely is the answer to that there, 100%. The better shape you're in beforehand, the better in likelihood you'll do afterwards, all right? Again, particularly with regards to a knee, all right? And a knee, I mean, if you look at your quads muscles on the front of your thigh, which allow you to straighten your leg, they're essentially like the engine for a knee, all right? And if they're extremely weak, which they often are because of the arthritis process, people get a lot of inhibition, all right? So that it's like your brain turns off the muscles in order to protect the joint, which actually then makes the joint worse. And unfortunately then when it comes to recovery in terms of trying to fire those quads and getting the knee to behave like it should, you need strong quads. So it often just has to be worked beforehand in order to strengthen up, and that's the number one thing that will improve their outcome for them, But yeah, absolutely. Again, in terms of when you think of getting up after a joint replacement and mobilizing with crutches, well, the more weight you're carrying, the harder that's going to be initially for that first couple of days, all right? So again, it goes without saying, the better shape that you're in, the better able you are to manage that.
Yeah. Can you tell me a little bit about the different types of joint replacement surgeries and, and why, as a surgeon, you might actually opt for those?
So in terms of joint replacements, there's actually not really a lot of difference as such, all right? So I suppose let's focus on the hip first of all right? So broadly speaking, you can offer a sort of a cemented hip replacement, as in one that is essentially glued in or grouted in as such into the bone, and a cementless one. And that has a sort of a rough coating over the surface of it that allows the bone then to grow onto the surface with time, and that's how it gets its fix as such in the bone. But within that then, because you've got the ball and the socket, you've got two different sides. So you can have cemented on one side as in the cup, or vice versa, right? And in general, it varies hugely. Some surgeons will use one type or the other for certain cohorts of patients. Others, I tend to use a cementless hip for the vast majority of all my hips, but again, that's just my preference. And ultimately, a lot of it comes down to your experience, what you're most experienced using. And I often say, like, even though strictly speaking, you can sort of have little nuances with things, you're more likely to get the best outcome with the prosthesis that you're most familiar with. All right. Knee replacements as well come with cemented and cementless options, and increasingly now we're seeing some cementless options there, but the vast majority of knee replacements are still cemented in place. There are sort of subtle different mechanisms in terms of how the two components of the knee fit and interact together. Some have a little cam mechanism, some have a dish, but I mean, it's getting into a little bit too much detail. And by and large, whatever works well for the surgeon putting them in is the way to look at it. Within these then as well, you can replace the whole joint, or you can replace part of the joint, all right, which is a partial knee replacement. And again, I often say to people, the first thing I do when I look and I see, is this someone for surgery, is can I get away with a partial knee replacement? And quite often you just end up replacing the knuckle on the inside as such. And so it's a much smaller operation. Much smaller operations come with, in general, a lot less risk, and a quicker recovery with a more natural feeling knee after it. So as I say, ultimately, roughly about 40% of the patients that I'll see would ultimately be suitable for a partial knee, and it's something to bear in mind. Again, the least I can put someone through in order to get them better is the way to think about it.
Yeah. And this is a question we're often asked, and it's about sort of the lifetime that you would expect, a joint replacement to last. Can you tell us a little bit about that? Because I know that again has changed and evolved in the last number of decades.
And this is the problem where it comes to sort of expectations and sort of lies, damn lies, and statistics type of thing. In that, and I'll sometimes put people on a spot a little bit by saying, well, listen, a prosthesis could last a year. It's quite possible. Something could happen, and the bone could fracture around it, could subside, could get an infection, and it could be out in a year's time, less even. All right, but on average, they're going to last very well, all right? And again, we've the benefit now of joint registries across the world, all right? Some of which have been going on for over 30 years, all right? Say like the Swedish Hip Registry, that type of thing. But the UK results are coming up, I think, to their 20th year this year, all right? So, and it tends to sort of mirror our practice the most. We have an Irish joint registry as well, but it's only in its sort of infancy, all right? But if you look at the figures from that, and 10 years is often a nice sort of way to quote. And again, it's actually very similar for a hip and knee in that the average hip or knee prosthesis has a 96% 10-year survival. Now, again, that I say to people, that does not mean you have to come and trade it in after 10 years. It is still going strong at 10 years, right? So essentially, you have a 1 in 25 chance of it not lasting 10 years and more, right? Now, with 15 years, 20 years, that'll figure drop down to sort of 90%, 85%. But I replaced a lady's hip there yesterday, and she had her other side replaced 29 years ago, and absolutely fine, all right? Cemented Charnley hip, and it's going strong, not a problem, all right? So one way there would be a nice way of looking at it, but it'd be hard to get the figures for it, is what are the chances in your lifetime that it would need to be done again, all right? Because ultimately that brings in the whole age spectrum into it, in that if you're 80 years of age and you're getting a joint replacement, almost certainly it's going to be fine, all right? If you're 40 years of age and you're getting a joint, the implications are a lot more, and that not only may it need to be or revised in your life, it might need to be done again. And it's like a way to think of it is that every time it's like a mechano set that just gets bigger and bigger. You need to bring in more bigger toys to allow you to sort of fix the problem as such. So,
Where does age feature in joint replacement surgery? Because there certainly was, there seemed to be, in years gone by, there was certainly this feeling that you're too young to have a replacement.
Yeah.
Or if you had a replacement under the age of 40 or even in your 40s, you almost certainly then had to have it. You'd be setting yourself up for another surgery down the line due to replacements.
So, yeah, I mean, I think it is an important factor, right, to bear in mind. And again, it's not that we don't always sort of, push sort of conservative measures initially, but in younger people, you're going to try your best, right? If an injection has given some relief, then you're going to try it again. And you're just trying your best to sort of, push people out, even that couple of years that they may not think is a huge deal. Yeah. But if that gets them in, a couple of further years down the line, it is a big deal potentially in 20 years down that line, And ultimately the way I'd say is that, well, again, if we go back to the same factors, right, your quality of life, if you're 40 years of age, right, and you can't sleep, like, as far as I'm concerned, you're looking at a joint replacement, assuming, again, the diagnosis is correct, right? And if everything else hasn't worked, well, then so be it, right? And as long as people are sort of aware that, yes, there is a chance that could need done again in their lifetime. Again, the way to look at it in many ways is you kind of, I don't see the sense in going, well, I'm going to ride out 20 years with a really poor quality of life just to get that joint replacement. That makes no sense to me, really.
Yeah. Equally, we're also living longer as a population.
Absolutely.
So do you find that has changed as well in terms of, again, you would have heard people in the past say, I'm too old to have a replacement.
Absolutely. In terms of, it's amazing. And we were speaking about it earlier in terms of the difference in, again, you've got your chronological age, as what I often describe, and your physiological age. And it is absolutely amazing, the difference. I see, I suppose I have the benefit of having a little sort of like peek look in at people's lives all the time, right? And you see people who come in and they're 50 years of age and they look about 80. You see 80-year-olds who would pass for 50. And that's the discrepancy that's there. It literally is about plus or minus 30 years in terms of how they look, act and feel often, right? Not actually, I hope he's watching this, but a few months ago, I replaced a knee in a gentleman, 93 years of age, all right? And essentially his knee was pointing the wrong direction. He couldn't do anything. And I replaced his knee and he was back playing golf at 8 weeks, all right? Wow. Which is, now again, it's like, am I going to say that everyone can get that? Absolutely not. But it shows you that it's possible. And I think it's important not to be too ageist. And we can be guilty of being ageist about it as well. Likewise, at the opposite end of the spectrum, right? We can be, oh, you're too young for that there. And I think that's almost equally as wrong. And I mean, ultimately, the one thing that younger people need to sort of realize is that, like, there's two aspects of it. Firstly, they potentially or hopefully have a lot longer to go in terms of their life expectancy, all right? And that could be, so someone 40, that could be 50 years, all right? Maybe more even, all right? But the second thing is that younger people tend to be a lot more active. So potentially they're going to use up a joint sooner as well. So there's two things, ways to look at that in terms of that why they may get through not only it having to be done again, but also then potentially done again if they're very young.
Okay. And you mentioned there earlier about the different types of prosthesis that may be used in surgery. Does the patient have a role, in making that decision with the surgeon, or is it, the surgeon that would entirely make that?
It's quite funny, and it'd be a bit of a contentious one. You do, I mean, some patients I see are pretty well informed, and I've had people come and see me going like, oh, and I'd read about this, about the partitioning, or I knew someone was talking to someone. That's exactly the symptoms that I have. Would I like it? Now, it's, I suppose, in that, not to sort of sound like, aloof in terms of, but like it's, I suppose, a little bit of a dangerous game to play someone coming in to what they'd like to do. And ultimately, I go back to, no, I mean, well, what's on the menu is what, as far as I'm concerned, what the surgeon uses routinely, all right? And if that's not for the patient, then that's potentially not for the patient, all right? But I mean, absolutely. We're living in a different world than sort of when you were that almost dictatorship almost of years ago where someone saw us and they were told that's what they needed and that's it, right? And yeah, absolutely, people have a right to sort of shop around. If they feel that something is for them, then so be it. I suppose in that regard, like there's a safety of little knowledge. There's then potential. You can almost sort of read yourself into a sort of and confuse yourself even more by going a little bit beyond that, because again, what you know, especially with the internet, what you're relying on is not necessarily fact. And we can talk conservative things. We can talk things like stem cells, all the different treatments now that come with, you know, a huge internet profile and yet potentially a very little sort of evidence for it. And you mentioned it in terms of, you know, like sort of the leading sort of things in terms of joint replacements, and quite often that's the enigma, in that what you need is something that's tried and tested and been around for a few years, because then you're not essentially part of an experiment, you know. I mean, I would much prefer to know that something had a track, at least medium-term survivorship in terms of its survival, all right, and how it does, and it's only with time that we know that.
So in terms of when somebody's going for surgery, can you tell us a little bit about what happens in a pre-assessment or pre-admission clinic?
Right. So certainly from the hip and knee point of view, all joints now are pre-assessed, all right? They have a pre-operative assessment. What is it? It's kind of like a little mini medical, that's it. Simple as that, all right? To ensure that someone is optimized for surgery is probably the best way of looking at it, and safe in many ways. So and so what do they do? They're seen by the nurse, the doctor on that. They get a little history taken of their previous medical problems. Their medications are looked into. They'll get their bloods taken there as well. So your things like your blood count, your kidney profile, that type of thing, all right? And they'll get a tracing of their heart, or an ECG as it's called. Some then, depending on whether or not it's felt or deemed necessary, will get things like an echocardiogram, which is an ultrasound scan of their heart. But again, it's all then just, the way I'll say it is, the more information we have, the less risk in many ways. If we know a problem is potentially there, it's rarely actually a problem. It's the patient who sails through these things without any, you know, issue that can cause trouble afterwards, all right? And, you know, they can have something that wasn't diagnosed, all right? And based on that pre-op assess, if more detail is needed, then we can ask a cardiologist to get involved, or respiratory physician, whoever is required to, you know, give the go-ahead. Now, the vast majority of people will just sail through that, there's no problems, all right? But obviously people who come with more baggage, more problems, all right, as such, all right, then we may need to pause just a little bit longer to ensure that they can be done. And ultimately there are some sort of higher risk patients who can only be done in a hospital with the full backup, but it's actually really quite rare nowadays that it's a very small minority of patients that aren't deemed suitable, all right, for whatever hospital they're attending, you know.
Yeah. And when we look at the other side of the coin, post-operative, what might somebody expect in terms of, you know, post-operation, in terms of their mobility, you know, their ability to do small jobs, you know, use the stairs, the toilet, and indeed even their in-hospital stay, because I know that's something that's really changed as well over the years.
Yeah, absolutely, and that is. So what I often say to people when they're sort of struggling the first day or two, like half the world are now performing joint replacements as day case procedures, all right? So they're going, you're discharged the same day, all right? Now, truth be told, what I particularly like to go home the same day, I don't think so is the answer, and I don't really prescribe it as such, all right? But for most, so say partial knee is often 2 nights in hospital, a full knee replacement 3 nights, a hip 2 to 3 nights again for us, all right? And I find that that's just the happy medium. By the time people are going home, all right, their sort of pain is controlled and they're safe and mobile in that regard, and they're confident to do the things, all right? So some people can, that day they're fine, right? But they're a little bit lacking confidence and they just wouldn't trust themselves very much. So I think a couple of days is absolutely fine. And so what? As I say, you get, you know, like mollycoddled for a couple of days and you get a little bit of, that's fine, all right? And that's, you know, I think they deserve it, all right, in many ways. quite often, especially with a hip, I think a lot of people are pleasantly surprised by that first couple of days and how quickly they improve, right? And so the first day can be a little bit trickier. By the second day, they're really starting to get going, and they're usually independently mobile up and down to the bathroom. Most people will be, again, with hip or knee, will be using 2 crutches for the first, whatever, week, 2, 3, 4 weeks, depending on how they get on and how strong they are, and how their pain is as such. But a lot of people are better off than they anticipated in many ways. All right.
Yeah. And in terms of occupational therapy and physiotherapy post surgery, would most patients need that? Or how does that usually work?
In terms of not so much occupational therapy. So occupational therapy is more looking into sort of like changing things in their home, and that would benefit. And again, you don't really need modifications like that nowadays. It's very different. A lot of the old sort of precautions and different things that used to be done with say hip replacements, and specifically a lot of that there has to a certain extent gone by the wayside. All right, now we still in general get people to lie on their back for the first few weeks, or most of us do, right? But to help, basically a lot of these precautions were designed to help pop the hip from popping out of the socket as such. All right, so as I say, that risk is much lower nowadays, so we can sort of pull back a bit on that. All right, but in general, occupational therapy, no. Physiotherapy, yes and no. I often say to people in that I'm firmly of the belief that less is more with a hip replacement afterwards, and I frequently see people sort of like overdoing it and irritating tendons, muscles, everything around the area, when I believe that it just needs a few weeks to just heal and settle down. A knee, and we spoke about stiffness, a knee needs to be moved and needs to get going in a slightly different way, and yeah, absolutely, it'll take a bit of work with a physio afterwards. And as much as anything, it's the exercises are easy. It's very, very simple in terms of what they do, but it's having someone there who's going to give you a bit of encouragement and go, come on, you can do 2 more, or knows when it's time to push you a little bit harder. And some people, a bit like, some people like a personal trainer, some people don't. Some people, for some people, that's absolutely gold dust. They love the having someone there to kind of tell them what to do. Others just don't. All right, and I mean, I'll get 2 types of people. I'll see the people who I was going to say need a little bit of a kick up the backside in order to get themselves going afterwards, and pardon the phrase, and then other people who I need to nearly pull the reins on to pull them back from doing too much. All right, so but again, we get all sorts that
people come in all different shapes and sizes.
Yeah.
Yes, exactly. In terms of people who maybe have been out of work to have their surgery, how soon might somebody expect to be able to return to work now? It's obviously a nuanced answer. It depends on what you do, I guess.
100%, all right, and that is the key, all right? So, I mean, a lot of people who can kind of sort of work from home, and particularly if they're self-employed, they could be on the ward the following day on their laptop doing a bit of work, all right? Now, I mean, even with that type of person, if they can sort of free up a week or 2, all right, then just for their own headspace, I think it's very important, all right? Now, the opposite of that spectrum is sort of like, a lot of like manual worker type things who are like, climbing up ladders and roofs. I mean, they could be out 3 months, even more, 4 months potentially, depending on really what they do and when they'll get signed off to be safe.
We've talked a good bit about hips and knees, and they're obviously the most common sort of surgical procedures for arthritis. But if you wouldn't mind just telling us a little bit about maybe other procedures that may be required sometimes in relation to somebody who's living with arthritis.
Yeah, I mean, so replacements exist for most joints, all right? Obviously, my area is hip and knee, which is what shoulders, increasing number of shoulders. Elbow replacements would be a sort of small enough number, but again, it's weight-bearing joints are much, much more likely to cause problems as the years go in as such. So that's why the number of hips and knees outweighs everything else, all right? I think they're like, the number, I think there's 6 times the number of people with either a hip or knee problem for every shoulder arthritis type of problem, all right? So that's probably always going to be the case because it's just a different joint that functions differently. Ankle replacements becoming more and more common nowadays as well again. And you've sometimes got, for other joints, you've other options in terms of fusions, all right? So an ankle it was very common to fuse the ankle or permanently stiffen the ankle rather than replace it. But yeah, more and more I'm aware now that they're starting to replace other joints, all right? Why hasn't it been done more and more over the years? Like, just the hip joint in many ways is quite simple, ball and it's a full ball and socket. The mechanics of other joints don't necessarily work the same and have been harder to replicate and with replacements, so that's part of the reason for that. In terms of moving kind of aside from that there, in terms of back to say the knee as such, and have you got any other options other than replacing the joint? Well, I spoke about a partial knee replacement. As well as that, you can sometimes knees would be suitable for things called an osteotomy, which is essentially, sounds terribly barbaric, but cutting through the usually the tibia bone, but it can be the femur, to essentially realign their leg. So, and again, going back, if all their pain is on the inside and they're loading the inside of the leg, and if you look around, you'll often see people with quite a bow on their leg. Well, then that's loading one side of the leg much more. And if you potentially unload that area as such by sort of straightening their leg, then you can take away their pain. And for younger people in particular, if you're 28 years of age and you've got well-established arthritis on the inside of your knee, well, you're not going to really be at the stage where a replacement is an option, all right, in all likelihood. So that's where things like an osteotomy really comes into the fore, you know.
And my final question to you today really is, you know, what would be your top tip for somebody who's facing surgery? Or top tips even? Yeah, in terms of top tips, I actually just remember, I never spoke about the disability again. I'd actually make a point of that at the end as well. But just in terms of top tips, all right? So I think there's a nice balance between being a little bit informed and knowing what you're getting on, right? And going too far into it, all right, and reading too much. And sometimes people almost like stress themselves out too much in terms of sort of reading up to what, or ask, and like, what I always say is just let it flow. Whether they like it or not, they have to place their trust in me or whoever the surgeon is, right? There's a certain element, it's like, again, for people hopefully not afraid of flying, but it's like getting on an airplane, right? You have to, you don't question the pilot and have a list of questions for them. There is an inherent trust that has to be placed in them, all right? And ultimately, you're reliant on the surgeon to do their part, and then afterwards they sort of worry about their part as such, all right? And in that regard, you find out as the journey goes on. So like, lots and lots of questions beforehand are going to be answered as you progress along that journey. And it's often a better way to do it, you know, knowing a bit, but just having that sort of, not sort of getting yourself too much into a tizzy, sort of worrying about something that's 8 weeks down the line when you have to get through today or tomorrow and such. And if you just take little steps, I mean, much as I said, a knee replacement is often really sore afterwards, right? And I don't say that to put people off. I just go, listen, you got to be able to trust me. I got to say how it is. Today is going to be crap. It's going to be, and you know, sometimes I'll put it in terms that aren't pleasant. But it's managing the expectation.
Exactly,
so
right?
It doesn't
if
come
you
as
know
a
that,
shock or a surprise.
And I go, you get through today. Tomorrow's going to be a bit better, and so on. And then they know that they can trust you in that regard. But yeah, so that would be my only tip, is just, yes, absolutely, get yourself ready in terms of, you know, being relatively fit, stronger. But, you know, there is very much a happy medium there, right, in every regard, right? And ultimately, I mean, if you can't say, if you can hardly walk because your hip is so worn, right, well, then there's only so much prehabilitation you can do, as in doing your exercise beforehand. And, you know, I'll often say, there's no point in hitting your head off a wall, right, beforehand and losing any momentum before you even start the journey of the replacement, you know. So, I spoke just much earlier about the disability, and I completely forgot to go back to it, because it's something that, particularly with actually both with hips and knees, that we see in terms of, so you've got your pain aspect, right, but then in terms of when a joint is worn. So from the hip point of view, you've got things like trouble doing getting on your shoes and socks, that type of thing, all right? Trouble getting in and out of a car, going up and down stairs. From the knees, particularly if the knee is worn in behind your kneecap, you've trouble potentially standing from a seated position. And this is something that particularly we spoke about as we get older in general. the more baggage you carry in terms of that disability, the harder it is to then do anything. And again, I'll often speak to people about their falls risk. If you've got a worn hip that'll give you a jar of pain every so often, and the leg wants to go, well, then potentially you're at a risk of falling and breaking your hip as such. So people looking to avoid an operation isn't necessarily the answer either, right? And you're going, well, what can I do to maximize the chances of getting someone back fighting fit again in that regard? I mean, we all know people who have, the last thing you need, if you're in your mid-80s, the last thing you need is something pulling you right the way down, like a sinking ship as such, like, you know, right? So you need everything going for you as far as I'm concerned.
Okay, Gavin, thank you so much. Thank you so much for joining us and for all your input today. Much appreciated.
Not at all. And again, thanks for having me. I hope I've answered more questions than I've raised.
Yeah, surely. Thanks you. And thank you very much for watching. For more information on surgery and arthritis, please log on to our website at arthritisireland.ie. You can also get further support via our online Facebook groups or via our helpline 0818 252 846. Thank you very much again to Gavin McHugh for joining us and for sharing his insights and experience. We look forward to seeing you again soon.